Hello, everyone. My name is student Dr. Chi. I'm excited to share with you all, again, my research that I completed over the summer of 2021 under the supervision of Dr. Mark Pence. Together, we conducted a research project that aimed to identify barriers and facilitators to accessing health services among underserved populations in Kansas City, Missouri, during the COVID-19 pandemic, using the social determinants of health framework. When I was already implementing this project, the Delta variant was just starting to pop up, and Omicron was definitely not a thing yet in June 2021. So over the span of a year, a lot has obviously changed. However, I do believe that my findings pertaining especially to social determinants of health among underserved populations in times of health crises are still pertinent today. So for our introduction, I am sure we all are well aware by now that underserved populations were disproportionately impacted throughout the COVID-19 pandemic. Using the Healthy People 2030 model, as shown here, we developed a study that identified potential facilitators and barriers to accessing healthcare services. For those that don't know yet, these social determinants of health are basically conditions in the environment that affect a wide range of health, functioning, and quality of life outcomes and risks. And according to Healthy People 2030, it includes these 5 pillars here, as you can see, such as educational attainment, access to healthcare services, neighborhood, social community, and economic stability. So simply put, we conducted a cross-sectional community-based participatory research study. So as Dr. O'Connor mentioned, research was definitely a team sport here, in which we partnered with 2 community clinics that predominantly served our target populations, Casey Care Clinic, as well as Samuel U. Rogers. We utilized self-administered surveys that were completed during health visits, as well at primary care clinics, as well as vaccine clinics, and descriptive analysis was performed. So what we were looking at here is just a summary of our variables in our study, which I have already mentioned previously. So for the sake of time, I'll skip this slide, but I do want to just highlight here the healthcare access pillar, which has been expanded. And as you can see, the barriers that we have, the variables we have looked at for our barriers. All right, so our target population here included low socioeconomic status, non-US born, and people of color. And over the short span of a summer, we collected 134 responses. 89% fit our target population. However, when we included people who indicated they were uninsured, 96%. And to identify our low income variable, we used the criteria of below the federal poverty level, which is less than $1,000 a month. And as I'm sure we can all imagine, living off of $1,000 a month is very difficult and arguably unfeasible, especially in these metropolitan areas. So when we included up to $1,200 a month, 99% fit our target population. So now on to the exciting part, some of our data. When we asked participants whether they were unable to access health services during the COVID-19 pandemic, almost 25% said they were unable to access a regular health checkup. This is especially important because 53% said they had at least one comorbidity that requires consistent health visits and also puts them at a higher risk of severe disease for COVID. So this is a busy slide. For the sake, I will skip it, but I just really want to highlight the importance of disaggregating data, especially when your outcome or one of your aims is to create targeted interventions for specific populations and subgroups. So for example, a common thing in the research is using the variable Asian, which is a very large homogeneous population that consists of various subgroups, ethnicities, and languages. So I just wanted to highlight that point here. Okay, so for next, when we asked about accessing health services, you can see here that 62% said they experienced at least one barrier to accessing health services. And I included the top 3 barriers and facilitators here. Overall, social determinants of health impacted population access to healthcare services during the COVID-19 pandemic in Kansas City, with economic stability, as you can see here, being the greatest barrier and social and community context as the greatest facilitator. Now, since I've given this presentation to both second and first years, I do want to highlight the cultural difference and linguistic barriers, which is something I have not yet talked about, but we'll highlight at the end. Family and friends was the most common facilitator to accessing health services and was also the main source of COVID information. And at the time of when we asked those that were unvaccinated, 40% were confident that they're going to get the COVID vaccine. And at the bottom, you can see here, 30% were not sure yet. Oops, sorry. Okay, so for my last slide, overall, these findings from this study informed the development of a multi-pronged strategy that addresses economic disparities, as well as utilizes social and community contexts to uplift marginalized groups. So for this study in particular, we advocated to Casey Care and Samuel U. Rogers to, one, provide more mobile clinics that specifically went to work sites. And accompanying these mobile vaccine clinics, we also wanted to include people that helped enroll individuals in health insurance, since those were deemed our greatest barriers. Now, as I promised, I will discuss a little bit about the cultural and linguistic barriers, which I was honestly very shocked at. Despite over 40% of our population being non-US born and limited English proficiency, only 3 individuals said that the lack of in-language resources was a barrier. And this contradicted definitely what I saw in the clinics. These individuals spent almost twice as long at their health visit compared to their English-speaking counterparts. On top of that, accompanying these individuals were family, friends, significant others. And in addition, each clinic had only one Spanish-speaking worker who wasn't even a translator. They were a nurse, a receptionist, a community health worker, having to fulfill dual responsibilities. Therefore, I'm saying that more research is needed to understand the perception of cultural and linguistic resource availability in accessing healthcare, especially among individuals with limited English proficiency. And with that, I am done, Dr. Talley.
Dr. Sarsour, did you have a question?
Yes. So my question to you is, how is there any comparison to another cities? You know, your study is in Kansas City. Did you try to find similar studies to see where we stand versus other cities? That will be helpful to see, you know, are really the situation is so bad, or, you know, is that something you looked for?
Yes, definitely. So a lot of major cities such as like LA, New York City, a lot of these big metropolitan areas do have research that shows that these individuals are facing disproportionate barriers to accessing health services, particularly highlighting economic stability. So commonly we can all imagine cost, insurance, having to take time off of work was a huge barrier, especially in these big metropolitan areas. However, what a lot of studies lack, which is something that I really want to highlight, was looking at facilitators. So what actually helped these people access health services? So maybe that could also be an important strategy when addressing these barriers, is utilizing these, for instance, family and friends to help these individuals. So although our study matched other metropolitan areas, saying that economic stability was the greatest barrier, we also were very fortunate to identify this facilitator. I also do want to highlight that there is also a need for non-urban settings. So for instance, in rural areas such as Joplin, they also face their own barriers and facilitators to accessing health services. So that is also something that needs more research.
Thank you very much, Lauren. That was wonderful.